All right. And today we are going to be covering a very exciting topic, and that is what chronic lymphocytic leukemia patients should know in 2025 with Dr. Alvaro Alencar. Dr. Alvaro Alencar is an associate professor of clinical medicine and chief medical officer at the University of Miami Silvestre Comprehensive Cancer Center. Dr. Alencar is a key leader in the lymphoma care space, and he serves as the lymphoma program director at Sylvester and the Lymphoma Committee for the Alliance of Clinical Trials in Oncology. Dr. Alencar has spoken for HealthTree before, and he's actually done one of my absolute favorite HealthTree University series. One of my favorite videos that we have is with Dr. Alencar, so I'm thrilled that he has joined us again today. And with that, I'm going to turn it over to you.
Thank you, Dalton, and thank you, HealthTree, for the invitation. It's really a pleasure to be here. I prepared some slides, and in reality, what I did, and let me share my screen, and you guys tell me if you can see it. Can you see it now?
Yep.
So what I decided to do is that since whenever I'm discussing data with patients, I'm actually referring to data that we see in our meetings, in our presentations, in ASH meetings, and so on. I said, why would I prepare slides for patients? It's the same data, right? So I am using the same slides that I use when I talk about CLL studies and talk about CLL with my peers. And obviously, we will try to do this in a way that is understandable, but I think that in the end, the data are just one. It's just one data that guides us, and I want to make sure that I'm able to share what is a journey through CLL therapy today and help us and the data that helps us make decisions for the treatment of our patients. So, and for sure we'll leave time at the end for some discussion. So these are my disclosures. I don't have to say much about the background of CLL. I think we're all very familiar that this is a very common disease. And as you saw in the presentation, I'm a lymphoma doctor, and is a misnomer that CLL is a leukemia, is a disease that you have circulating cells, but it's mostly a lymphoid malignancy, a lymphoma. So when you see statistics about CLL, you'll see CLL in the breakdown of non-Hodgkin lymphoma presentations. And we have over 20,000 new cases a year in the United States, a disease more of older patients, even though we see CLL in younger patients. But if you see here, you have CLL really starting to present in the late 40s and the 50s, and then peaks in the mid 60s, 70s, and then still having older patients in the way into their 80s still being diagnosed. And what we're seeing is that we're having better and better care, and therefore, thankfully, we're seeing less and less patients dying of CLL in current era, which is extremely important. And important to remember that sometimes when we ask Dr. Google what is going to happen with me with CLL, Dr. Google may use very old data. So we have to be very careful with the outcomes of CLL because they're literally changing daily as we have more and more therapies. So we know that we have different therapeutic classes, and we see here chemotherapy in the bottom, which is something that we probably barely use today. So today the therapies are based mainly on the BTK inhibitors. We're going to talk about it. And there's a little star here because Acalabrutinib, Ibrutinib, and Zanubrutinib are covalent BTK inhibitors. Pirtobrutinib is a non-covalent. There's a little difference between them. We'll talk a little bit about it. BCL-2 inhibitor therapy, mainly with venetoclax. We have antibodies targeting CD20. Obinutuzumab is the most common agent. There is a G because sometimes when you see in the studies, obinutuzumab is actually simplified as a G instead of an O because that was the original name when the drug was initially being evaluated. Rituximab is an older monoclonal antibody that has activity in CLL, but not as good as obinutuzumab. We used to have to increase the dose of rituximab to be able to use it. We barely use it nowadays. And when we're talking to patients, obviously, I'm sure you're all very familiar with the idea that we don't always treat CLL. There are indications for therapy. The disease needs to be causing trouble and needs to be really having a reason to treat. But when we're decided that, yes, we need to treat CLL, there's really a list of things that we go through to decide which drugs to use. There are some molecular studies, some DNA changes, things that guide us on the expectations of response to therapy, prognosis, but it's not only that. It's really the entire profile. What is the patient's expectations, their lifestyle, their access to the cancer center, to a local hospital or a lab, or their interest in an infusion pill. So all these things really need to be taken into consideration all together when we're making decision for for the CLL treatment. And yes, we have different prognostic variables, and we talk about the cytogenetics. That a lot of times we check with FISH, like deletion 17p, 11q, trisomy 12, or really things that we detect with DNA sequencing, like TP53 mutation, which is a marker of a more resistant disease. That thankfully the drugs today are really overcoming this resistance. And the mutation status of IGVH is also very important. The karyotype, what is so all these features will help us understand what to expect from the disease when we are starting treatment. Some are more or less responsive to X or Y or Z agents, and some are expected to cause trouble earlier if we're not treating, and even it's still debatable whether we should check this molecular test in every single patient at diagnosis. I tend not to, because we know it's important. It helps us understand and predict, but still what really guides us on therapy is the indication for treatment, not yet the molecular features. They will have an implication when we're deciding therapy. So that is just to keep in mind when we're talking about the initial diagnosis. But when we decide to treat is really today is this balance between a BTK inhibitor with Ibrutinib, Acalabrutinib, Zanubrutinib in first line versus a BCL-2 inhibitor with a venetoclax. We're going to go with this in a little more detail, but you all, I believe, are familiar with the idea that a BTK inhibitor is an easier drug to start, tolerated usually really well. We have some important side effects, but it's a lower risk therapy that patients start taking, and usually we'll see them a month or so later, and tends to have excellent response, even in some very high risk features, while BCL-2 inhibitor venetoclax is also extremely effective, but requires a little more attention when we're starting treatment. There's something called tumor lysis syndrome. The CLL is so sensitive to this drug that it just melts away, and we need to be cautious with the kidney function and making sure that we are preventing problems, and this requires more visits to check labs, to come to the infusion center. So a little bit more of a commitment, but the main difference when you're balancing out these two options is that therapies based on BCL-2 inhibitor, venetoclax, tend to more frequently be finite. You use it for a period of time and stop, while therapies based on BTK inhibitors tend to be indefinite. And this is because of the way we're addressing CLL. In the long run, tends to be mostly the same, but I describe to patients that when CLL we decide to treat is like when a lion is coming to attack you. And you either put the lion in a cage with a BTK inhibitor, so the lion is alive, growling, but is inside the cage, and as long as you're taking the pill, the lion is in the cage, alive, but not attacking you. So in most cases with a BTK inhibitor, you control the disease, but uncommonly going to have deep remissions. Most patients have partial responses, enough disease control, enough control of the symptoms, but the disease is detectable. And that's okay, because we keep excellent control of the disease. But if you stop taking the pill, you open the cage, the lion is out. For venetoclax, a drug is like a dart that puts the lion to sleep. So there's no cage. The lion is there on the floor sleeping, and it's not going to attack you, but eventually it's going to wake up. So as long as the lion is sleeping, we're fine, but eventually we're going to need therapy. So that's the process with venetoclax. Venetoclax-based therapy is a certain period of time, puts the lion to sleep, allows us to stop and hang out, and then eventually the lion wakes up. We have to decide what to do. So these are basic principles that help us understand, because this, combined with all the other features we just spoke about, will decide how we're going to decide which one is best for the patient. So BTK inhibitors function in a way that you block a receptor in the surface of the cell that leads to a cascade of events that leads to cell proliferation, multiplication. So the cells stay alive because of these activation process. And when you block this cascade of events by blocking BTK, you stop this proliferation, you stop the signal for the cell to do all the bad things they're supposed to do. So that's how the BTK inhibitors are so efficient, because they really impact a critical pathway on the survival of these cells. And one thing that is very interesting that's part of this process is that these cells are happy in their environment, inside the lymph nodes, inside the bone marrow. And when you block BTK, they kind of get lost and they tend to leave their environment and go to the peripheral blood. And that's why you see a lot of times when patients start therapy, their white count goes up really fast before it goes down. These cells are kind of kicked out of their house and then go to the peripheral blood, and it will slowly die in the peripheral blood. So it's part of this process of blocking these cascade of events that let the cells survive and expand in their little environment. On the other hand, venetoclax is a drug that really works in a key point of the cell, which is cell survival. So there's this part of cell survival process called BIM, and when you impact BIM, you really lead to the apoptosis, you lead to cell death. So venetoclax is very good in inducing cell death, and that's why all this breakdown and the caution that we have to have with the tumor lysis syndrome. So in very basic terms, the difference between these two agents and how they work against CLL. So what I'm going to do now is travel through all the data that led to the use of these drugs. And for BTK inhibitors, the most expansive data that we have is with Ibrutinib, because it was the first drug that was approved. So we'll start with Ibrutinib and then see the data for the other agents, Acalabrutinib and Zanubrutinib, for first line. So Ibrutinib was first evaluated quite a long time ago. You see, this study was published in 2015, compared with chlorambucil, which was a chemo pill, very little activity, and you see incredibly better. The curves are so dramatically different in progression-free survival between Ibrutinib and chlorambucil, obviously much better. But if you see in these tables here, most patients will have partial responses, which are these bars in blue. Complete responses are uncommon, but they tend to improve over time. So as you expand your use of this drug, you see that more and more patients have complete responses over time, so reaching up to 30% by 60 months. So this is a drug that is very effective, majority of times partial responses, but CRs are possible. And when we follow these patients in the long term, we see that these patients continue to have excellent response. You still see patients progressing, so people will get out of this drug, sometimes because of toxicity, sometimes because of really development of resistance, but the drug's still demonstrating excellent disease control 8 years later. And one thing that is very important with BTK inhibitors is that you demonstrate this activity when some very important high-risk groups, such as deletion 11q, mutated or unmutated IGVH, and you keep this in mind when we talk about venetoclax, for example. So we're seeing excellent disease control even in higher group of patients. But obviously, as you expose to patients for a longer period of time, you improve the responses, but also you have more time to develop toxicity. So you see some toxicities, as for example, hypertension, occurring later on, years after you start the drug. Some of them are very minor and happen throughout, like, for example, the bleeding associated with BTK inhibitors, the arrhythmias like atrial fibrillation that happens more frequently with Ibrutinib compared to Acalabrutinib and Zanubrutinib, but they tend to happen kind of all along the treatment, but some, like hypertension, tend to happen later on. So some of the focus today in trying to see if we can stop therapy are really related with the possibility that by exposing patients for a long period of time, you're just exposing them to the risk of toxicity for longer. But the data was very promising, and then what led us to do what we always do in medicine whenever we have a very effective drug, is that compare to the standard. And the standard that we had back then was combination of chemotherapy with immunotherapy, and one of the drugs that we used to use was called bendamustine. So when you compare Ibrutinib versus bendamustine, and both of them potentially with rituximab, so bendamustine with rituximab compared to Ibrutinib with or without rituximab, Ibrutinib was clearly better than chemotherapy, and this killed the use of chemotherapy in CLL. But bendamustine was a less intense therapy that was used with younger patients. So I was like, okay, fine, it's good for, I'm sorry, for older patients. But then there was FCR that we're going to review later. So Ibrutinib, much better than bendamustine, clearly superior. Maybe you're not seeing much difference when you add anti-CD20 antibody, when you're adding rituximab to ibrutinib. Maybe the problem is that rituximab is not the best drug for CLL. But here, what we see is that the arms that had ibrutinib, much better. And you see this in the long term, the same thing. We continue to see this benefit in progression-free survival. It's very difficult to see overall survival benefit in CLL because these patients can progress on bendamustine, get a BTK inhibitor in second line, and still get the benefit from that drug. So on that study, it just showed that in first line, in the beginning, ibrutinib was better. But then it was like, okay, better than bendamustine, but what about FCR? FCR was a combination that was incredibly effective in treating CLL and even potentially curing some patients. That was the possibility that FCR was curing some specific subgroup of patients that had a mutated IGVH. And when we compare with ibrutinib, we see again, ibrutinib clearly better than FCR. So even the more intense regimen that was only used with younger patients because it was associated with more toxicity, mainly infections and low counts, ibrutinib was still better. And it was still better even in the subgroup of patients that had theoretically this cure with FCR. So this also killed FCR. FCR is done. No bendamustine rituximab, no FCR. The standard for first-line therapy was really a BTK inhibitor. And because the rituximab didn't really add much, it was really a single agent BTK inhibitor without a monoclonal antibody as first line. So this kind of cleared the path for BTK inhibitors in first line. But as we saw, ibrutinib had some issues. It had the issue with atrial fibrillation, the issue with the hypertension, the issue with the bleeding. So as we always do, we started developing second generation drugs that are potentially better. And one of the drugs was acalabrutinib. So acalabrutinib was evaluated in first line in a study called Elevate. On this study, we're again comparing versus a chemoimmunotherapy regimen, now obinutuzumab with chlorambucil, that same pill that we evaluated ibrutinib in the beginning and clearly didn't have a lot of activity, but also evaluating acalabrutinib with or without an antibody, this time obinutuzumab. And what we see in this study, again, is the same thing. The arms that received acalabrutinib dramatically better than the chemoimmunotherapy arm, but we see something very interesting. There is a little difference between the acalabrutinib with or without obinutuzumab. By adding obinutuzumab, you had some complete responses, which is something that we don't typically see when we use BTK inhibitors by themselves. But obviously, if you do this, you add a little bit of toxicity. So there's the issue with the infusion reaction with the obinutuzumab, which is manageable, is absolutely doable, but it's an additional toxicity, more drop in counts. So you pay a little price for that. But it's very interesting that even the 6 months of infusion of obinutuzumab in the beginning still reflect in better progression-free survival years later. We're seeing here at 72 months, and we still see the curve of the patients that received acalabrutinib with obinutuzumab better than the patients that received acalabrutinib alone. Forget the chlorambucil arm. That arm is clearly inferior, but suggesting that maybe some patients could benefit from the addition of obinutuzumab to a BTK inhibitor in first line. But when you look in more detail, this is very complex graphic. You're going to have to trust me a little bit here, but what we see is that obinutuzumab helped the patients that needed it the least. So the high-risk patients, the patients with 17p deletion, TP53 mutation, didn't really benefit from the addition of the antibodies. So in those, the only patients that benefited were those patients without high-risk features. And those patients that are responding really well to BTK inhibitor already. So why are you going to add an antibody to these patients? Maybe you're going to improve progression-free survival, but you're going to have more toxicity, more infusion, more issues with infection. Doesn't really seem to be worth it. So it seems that it adds some benefit for some groups of patients, but the patients that really need it don't seem to be the ones that really benefit. And when we look in overall survival, it's not that different. You still see that the overall survival is mostly similar. And again, it's the same idea. It is very difficult to show overall survival benefit in CLL. And when we look at this very complex graphic of toxicity, so again, you're going to have to trust me a little bit on this one, but when you add obinutuzumab to acalabrutinib, you see a little bit more of drop in blood count. So you see more neutropenia, a little bit more of infectious complications, a little bit more drop in blood count. Doable, but again, not sure if it's really worth the hassle of adding a drug without a clear benefit in the long run. And then comes Zanubrutinib, and Zanubrutinib was also evaluated in first line when compared to bendamustine rituximab, kind of the same idea, in a study called Sequoia. One thing that is very interesting on this study is that they evaluated separately a group of patients with 17p deletion. Patients with 17p deletion are felt to be completely resistant to chemotherapy-based regimens like FCR, bendamustine rituximab. So it's not really ethical nowadays that we have these drugs available to expose these patients to bendamustine and rituximab. But we want to see how the activity of these BTK inhibitors is in first line in this group of patients. So this study did evaluate separately this specific group of patients. And again, we see the same thing. Zanubrutinib clearly better than BR, no much difference in overall survival. This benefit seems to benefit all subgroups of patients, but one thing that is very interesting is that you see an excellent benefit in patients without 17p deletion. Again, not much difference in overall survival, but what is very interesting is that when you see patients with 17p deletion, there's not much difference in those numbers compared to patients without, really showing that BTK inhibitors can overcome this resistance from 17p deletion, even in first line, even with a single agent like zanubrutinib. So this is very important because we know that 17p deletion is associated with worse responses, faster return of the disease. So the fact that we have a group of patients showing excellent response rates is extremely encouraging. And here is just showing the safety, and bendamustine and rituximab was obviously more associated with low blood counts, infections. Clearly, the BTK inhibitor, the targeted therapy, was better. So all these therapies were comparing a BTK inhibitor with a chemoimmunotherapy. But what if you compare them head to head? And we don't really have data for this in first line, but we have data in relapse disease. And we've been using this data to extrapolate a lot and help us decide which drug to use in first line. And this is what I would like to share with you a little bit. So one is the data with acalabrutinib, and there was a study called Elevate RR, relapse refractory, that compared acalabrutinib with ibrutinib. And the endpoint of the study was to show that acala is not inferior to ibrutinib, that is just as good, but with better tolerability. And what we see in this study is that they had a very complex evaluation that if one was not better than the other in the responses, then you're trying to see if the acala is better than ibrutinib in other features. And we see exactly that. Acala is exactly the same on the curve of progression-free survival as ibrutinib, so it's just as good, not inferior, so it's just as good. And when we evaluate toxicity, acala is clearly better than ibrutinib with less atrial fibrillation, with less cardiac toxicity. So same efficacy with better tolerability. We still don't see difference in overall survival. That is okay, but some key features like hypertension, fibrillation, arthralgia, so a joint pain, all of these curves, you see the blue lines with acalabrutinib better than ibrutinib. So same efficacy, better tolerability. So obviously, we're still good with ibrutinib. It's still okay. We still have reasonable tolerability, but if you can get the same response with better tolerability, why not? And when we see why patients stop therapy, more frequently patients will stop with acala because of progression, so really because of issues with the disease progressing through the drug, while more frequently patients with ibrutinib would stop therapy because of toxicity. So really showing that ibrutinib has a little more problems with toxicity compared to acalabrutinib. And when we compare zanubrutinib with ibrutinib, it's kind of the same idea. So in this study, it was a little bit different. Remember that in Elevate, we're talking about non-inferiority. On this study is a superiority study saying that zanubrutinib is better than ibrutinib as far as responses. And we see that. We see that we have a higher response rate with zanubrutinib compared to ibrutinib, and this reflects in actually a little bit of a better progression-free survival. So we can't really compare studies, and we're not really able to do that. It's different study populations, it's different targets. But what we can say from both studies is that both studies reached their target or reached their goal, is that showing that the drug is either as good as Ibrutinib when we're comparing Acala, and Zanubrutinib was better than Ibrutinib as far as responses, with a little bit better progression-free survival. And again, showing this advantage even in the higher risk population with 17p. Still no difference in overall survival. But one thing that we see with Zanubrutinib is that it is better tolerated, but not as dramatically different as we see with Acalabrutinib. So you have less cardiac toxicity, less atrial fibrillation, but pretty much the same amount of low blood counts, the same amount of hypertension. So maybe the take home is that maybe Zanu is a little more effective, but the price that we pay for that was maybe a little bit more toxicity. So this is another thing that we use when we're balancing out which agent to use. And here is just a breakdown of the toxicities. But when we follow in the long run, is the same thing. We maintain the efficacy even in the high-risk patients. Still no difference in overall survival, but clearly demonstrating that Zanubrutinib is better tolerated in some features like cardiac toxicity, around the same in other one, but maybe slightly more effective than Ibrutinib. Here is the difference in atrial fibrillation, which is very important because this is one of the most important arrhythmias with BTK inhibitors. All right, so we talked about that, but let's now shift gears a little bit with venetoclax. And we talked about the issue with venetoclax and the tumor lysis syndrome and the importance of having the escalation of the doses before we start therapy. So we have to be careful with bulky disease. We have greater risk of having this toxicity. We ramp up the doses. We have to check labs very frequently. So that is the reason why venetoclax is not as easy to give in first line. And we also have data with venetoclax demonstrating superiority to chemotherapy. So here is the Murano study. It's in relapsed disease, but compares venetoclax with rituximab versus the same bendamustine and rituximab. And we once again see the clear superiority. Clearly better, venetoclax versus bendamustine and rituximab. And here we start to see an interesting thing, which is MRD, measurable residual disease. We remember the line is put to sleep, so we may be able to not even detect disease at all, something that we don't really talk much about when using BTK inhibitor by itself. But what we see here is that obviously patients that have better responses, undetectable, measurable residual disease, they will have longer time to progression, maybe even an improvement in overall survival, but something that we don't talk too much with BTK inhibitors. This was so good, obviously, that we evaluated venetoclax in first line. Now we do this with obinutuzumab because it is a better monoclonal antibody. We compare with the chlorambucil obinutuzumab the same way, and what we see again is the clear superiority. Once again, venetoclax much better than chlorambucil when combined with obinutuzumab. No big surprise. But one thing that we start seeing that we didn't see as much with BTK inhibitors is that there is a more impact from TP53 mutation, 17p deletion, IGVH mutation status. So maybe there is a little problem with venetoclax when we're using in this higher risk patients. It's still incredibly effective. We still have a lot of undetectable MRD, but we have potentially to be a little more cautious when we're evaluating patients with high-risk features. It's still active, it still shows incredible responses, may still be a very reasonable option, but we have to be a little bit careful because you may be losing a little bit of the response when we are using compared to BTK inhibitors. So when I'm presenting this to patients, I say, listen, we have to keep in mind they may be a little different, but still, it is a very effective combination to use. But what we're seeing is because of this deep responses with venetoclax and the interest in using abbreviated therapies, more and more we're seeing combinations of BTK inhibitors with venetoclax. So we have, for example, the study GLOW that compared Ibrutinib with venetoclax versus chlorambucil and obinutuzumab. Is the same story, clearly better, much better. And this clearly led even to these studies that combine Ibrutinib with venetoclax, even led to the approval of this combination in Europe, Latin America. Here in the US, it never really caught up too much. It's in the NCCN guidelines, so some doctors may use it, but it never really made it to FDA approval as it happened in Europe. But we have a lot of studies that are evaluating ibrutinib with venetoclax. And here, for example, the FLAIR study comparing with FCR, which is that very effective chemoimmunotherapy regimen. And we again see ibrutinib venetoclax clearly better than FCR. Another study, Captivate, the same idea. And even with the possibility of doing this finite therapy, you do for a period of time, stop and watch. And what we see with this is that it is good. Even in the higher risk patients, like for example, the 17p deleted patients, they may relapse a little bit earlier, but still excellent disease control with a finite therapy. And what is more interesting is that when these patients relapse, we're able to reintroduce the therapy and still have responses. So still showing that a combination is very effective. But if 2 are better, what about 3? So we have, for example, the study CLL13 that evaluated a chemotherapy arm, a venetoclax with rituximab arm, a venetoclax with obinutuzumab arm, and an arm with venetoclax, obinutuzumab, and ibrutinib. And what we see in this study is that when you use a triplet, you clearly have more undetectable MRD compared to the doublet, but the difference is not that big. We also see in this study, once again, that the obinutuzumab is clearly better than rituximab. But when we see in the long run, the triplet is not that much different than the doublet. And we have a little more toxicity. So suggesting that maybe the Goldilocks in CLL rests in doublets and not in triplets. So very careful when we're still maturing this data, trying to understand better, but there's a strong signal that maybe the best approach for patients in CLL is using doublets versus triplets. And we see this in a study that really may impact how we treat this CLL in the US, which is the Amplify study that was just presented at ASH a couple months ago. So in this study, we're using now acalabrutinib, the same idea, acalabrutinib with venetoclax with or without obinutuzumab versus chemoimmunotherapy. Forget the chemoimmunotherapy. The important take-home points on this study is that obviously the non-chemotherapy approaches are much better. We have better disease control with the triplet compared with the doublet, but that comes with a price. There was certainly more toxicity, and the study was conducted in the time of COVID, so we see a lot of COVID deaths related to this therapy. It was just a reflection of the additional immunosuppression from the triplet compared to the doublet. So maybe a little better response, but with a big price to pay. So just showing that once again, that maybe in CLL, the ideal for a finite chemo-free, probably fully oral combination is a combination of a BCL-2 inhibitor with a BTK inhibitor. And we expect really that this combination will be approved here in the US very soon. But unfortunately, what we have today is that we still see many of these patients, unfortunately, still relapsing, having issues after being exposed to BCL-2 inhibitors, after being exposed to BTK inhibitors. And what do we do today? What happens when you have failures of both venetoclax and BTK inhibitors? One of the main drugs is really pirtobrutinib. So this is a non-covalent BTK inhibitor. It's a drug that was designed to address a problem that leads to the resistance to the covalent BTK inhibitors. And this study called BRUIN evaluated different types of B-cell lymphomas. We're going to focus obviously on the CLL cohort in this study. It was a group of very high-risk patients. As you can see here, a lot of patients with 3-4 lines of therapy. Most of these patients with high-risk features. A lot of these patients with mutations that lead to resistance to covalent BTK inhibitors. But we still see excellent response rates, great responses, even in patients that were refractory to a covalent BTK inhibitor, as expected for a BTK inhibitor, mostly partial responses, but still excellent disease control. We see excellent disease control in patients that were exposed to BTK inhibitors and BCL-2 inhibitors. Maybe those that didn't have previous venetoclax have response a little bit higher, but still in both excellent disease control, even in this highly refractory patient population. And we see this with excellent tolerability. We see the adverse events very, very, very minimal. So an extremely well-tolerated drug with excellent activity, even in patients that unfortunately had issues with covalent BTK inhibitors and BCL-2 inhibitors. So pirtobrutinib is an excellent option, but not the only option available today for this group of patients. The other option is cellular therapy, CAR T-cell therapy, and lisocabtagene maraleucel is approved for treatment of CLL, and this was based on the study Transcend. So it's a complex study. It's a complex therapy, but still something that has a role today. We don't use it very frequently. It's something that it really involves a lot of things, collecting cells, waiting for cell production, infusion. And it's difficult to do this when you have certain, such as so easy as pirtobrutinib, for example. And this is kind of competing options for the same group of patients. But we still see that this is an option that is available, not available to everybody, unfortunately, because there's still limits of limited access to these therapies throughout the country, mainly throughout the world. But we see that in this highly refractory patients, you see patients with very resistant disease, we still see incredible responses, usually with very good tolerability. So it is really an option that we have to consider today, even though it might not be available for all of our patients, because maybe it's too complicated. They don't want to be dealing with the cell collection, putting catheters, staying in the hospital for infusions and all that. But it's certainly something that we will consider today in specific cases. So this is the tables with the tolerability showing the most toxicity are grade 1 and 2. So usually something very well tolerated, but obviously something that we use less frequently. But still, we have problems. Not all the time. These are available, not all the times they work. So what's coming? What is next? And one of the things is bispecific antibodies. So bispecific antibodies work like CAR T cell therapy. They have two arms. One arm, they grab the immune cell. One arm, they will grab the CLL cell and put them to fight. And they kind of the same idea as the CAR T cell therapy when you teach the lymphocyte to attack the CLL cell. And we have more and more data showing that these antibodies are very effective in CLL patients, the same highly resistance features like TP53 mutations and so on. And the other option that we're seeing more and more are BTK degraders. So BTK inhibitors target the receptor, but we know that even if you completely eliminate the receptor, there's still downstream activation. So a BTK degrader completely eliminates the receptor and has activity even when BTK inhibitors stop working. In a study that evaluated one BTK degrader called NX-5948, we're seeing in a group of patients with CLL with a lot of previous treatments, also excellent responses, even in patients with very high risk mutations. And we see this again with very reasonable tolerability. So what can we say? We have so many options today. We're still based mainly on the BTK inhibitor and BCL-2 inhibitor. We have more and more newer strategies, better ways to combine these drugs, better drugs that are even better tolerated, drugs that are even more efficacious. So the landscape in the long run, it is really incredible. And I'm sure that we're able to really treat the great majority of CLL patients today. It's just a matter of understanding what is the best option for each one of them. And I'll stop here. Happy to answer any questions. Thank you very much.
Thank you for that presentation, Dr. Alencar. That was super, super informative, and I think did a really good job of shining light on CLL. There's been so many advancements that now it's not the question's what is the best treatment, not is there treatment, which I think is just fantastic. Um, so we do have a couple of questions that are starting to come in. If you are watching on the HealthTree website and you want to ask a question, click on the little button on there that says go to Zoom or ask a question here. And that'll take you into the Zoom so that you can put your question in the chat. Let's see. So Mike asked, do you have any thoughts or data on the Celestial trial? So again, kind of looking forward about new things on the horizon here.
Sure. I think that the main issue that we have with the Celestial trial is that it was trying to understand a drug that we don't really know what to expect, right? So it is very encouraging to have sonrotoclax evaluated. Sonrotoclax is a drug that seems to be even better than venetoclax. So we're still maturing on how to use the drug, how to understand the drug. So the study was very provocative, right? So using Zanubrutinib for some might be the best BTK inhibitor, combining this with sonrotoclax, which seems to be better than venetoclax, combining with a venetoclax-based standard of care with venetoclax obinutuzumab. So I think this is very provocative. The data was very encouraging. So I think that we'll definitely see more of that. But I don't think we can get much more than this right now because we don't even understand really how sonrotoclax best fits in the CLL scenario today. So I think it will be very difficult for us to just jump straight to sonrotoclax, zanubrutinib in first line without really understanding how the drug will unfold.
And then another question that I got was if someone is currently being treated with a BTK inhibitor, but we know that there's other BTK inhibitors, are they able to switch from one to another down the road? Is that feasible? How does that work?
That,
Does that have decreased efficacy?
that's a phenomenal question, extremely important question. I thank you for asking this question because this is something that is very important. So I explained to you that we have covalent BTK inhibitors, Ibrutinib, Zanubrutinib, Acalabrutinib, and the non-covalent with pirtobrutinib. These drugs, from the data as I showed you, are the three covalent ones are mostly similar as far as efficacy. So while sometimes you may be on one and you develop resistance to it, and you might be able to get another one, in general, the mutation that leads to resistance to covalent BTK inhibitors, the C481S, leads to resistance to all covalent BTK inhibitors. So it is extremely unusual that if you are on one covalent BTK inhibitor and you develop resistance, that you're going to have response with another covalent BTK inhibitor. On the other hand, if you are having a great response and you have issues with tolerability, so let's say you are on ibrutinib and you have horrible hypertension, but you're having excellent response. It is possible that you can switch to a second generation one, maintain that response, and have less issues with toxicity. So if you're switching between the class because of issues with toxicity, perfectly fine. But it's highly unusual that if you are progressing in one covalent BTK inhibitor, that you're going to be able to switch to another one and get a response. Because usually the reason for the progression, you progress on something that makes it resistant to the class. Now you can switch to a non-covalent BTK inhibitor, and then it's a different story, right? Because we show that pirtobrutinib, the non-covalent, works even when covalent stops working. Obviously, there are all little details. Sometimes non-covalent works again, and when non-covalent works, but usually is the same idea. If a non-covalent stop working, so pirtobrutinib stop working, is unusual for a covalent to work again. But this is the idea. If it is progression, changing to the same class, unlikely to work. If it is an issue with tolerability, absolutely yes.
And then another question that I got messaged to me was if I have a family history of cardiac issues, should I be wary of taking a BTK inhibitor?
That's a very important question, and the answer is no. So for two reasons. One is that family history may represent an increased risk. Absolutely, yes. But we know that even in patients with cardiac history, today we know that with the second generation agents, the risk is so much smaller that we are comfortable in starting a BTK inhibitor, even in patients with history of atrial fibrillation, even in patients with history of some cardiac dysfunction, because we know that in majority of times, these are safe even in these settings. And in the most times, we are able to simply stop, manage, reverse if we're having problems. Typically, the issues are hypertension. So a lot of times we don't even have to adjust antihypertensive medication. Sometimes we do have to add one or increase the dose a little bit. But most of the times, these cardiac toxicities, mainly with the second generation ones, are very minor. Yes, you have report of sudden death with BTK inhibitors, of really serious arrhythmias. This is obviously reported. This is obviously very well known. But unfortunately, if you look for every drug is going to have some reported serious toxicities. But we know that as a whole, when you see the percentage of toxicity with this class, mainly the second generation ones, Acal and Zanu, are safe even in patients with cardiac history. So even more for those who have only a family history of cardiac toxicity.
It's good to know. And if you're curious to learn more about that topic, I did want to let you know about a future webinar that I'll be doing with Dr. Carrie Rogers, where the whole webinar will be discussing BTK inhibitors in cardiac health. So for the person that sent that question in, that might be another webinar that you would be interested in. Um, let's see. This one I'm going to try to make a little bit more general. Um, let's see. So if a patient starts on acalabrutinib, um, should they expect their white blood cells and hemoglobin to return to a more normal level, or would you still expect those to be elevated?
So obviously, a lot of times you're starting on therapy because you have anemia, right? So the anemia is the reason to start treatment. And most of the times you have anemia because you have a lot of CLL in your marrow and your marrow function is not really adequate. So as we spoke a few minutes ago, when you start BTK inhibitors, very frequently you're going to see this rise in the white cell count as the cells shift their location from inside the marrow, from the lymph node, from the spleen into the bloodstream. So very commonly, the white count will go up. As we do this, we expect hemoglobin and platelets to improve, but it may not happen right away. Sometimes you may see the marrow kind of tittering and still dealing with not only with the CLL that is still very prominent, but still dealing with the new drug starting to come in and make all these changes in the marrow environment. So it's not uncommon that you're going to see a dip before you see a rise because you're still dealing with a lot of disease in the beginning. And this happens especially in patients that may have hemolytic anemia. Now, so not only issues with the production of red cells, but also production and destruction. So yes, you do expect that as you improve disease control, you're going to see improvement in hemoglobin, improvement in platelets. But we know the CLL makes a significant dent on the marrow function. So it's not uncommon that you're going to have to be a little patient before you see really a good incline in a rise in the hemoglobin levels, especially platelets, but it's taking even a little longer.
All right, and then this is might end up being our last question, but I think it's a really good one to cover. So if a patient is on quote unquote watch and wait, term that we are all familiar with and love, and they have progressed and needs treatment, but doctors can't determine if that patient has CLL or mantle cell lymphoma, what treatments could be given to this individual?
So this is a very common problem that we have today. CLL and mantle cell lymphoma are like cousins. They share a lot of similarities, and sometimes it's very difficult to tell one from the other. So mantle cell lymphoma is really a disease that I say wants to be CLL when it grows up, because a lot of the therapies that we use for CLL now are starting to be used for mantle cell lymphoma. So mantle cell lymphoma tends to kind of follow a few years behind. So we're seeing with mantle cell lymphoma today what we saw with CLL as we reviewed on the slides years ago. This less and less use of chemoimmunotherapy, greater and greater use of BTK inhibitors. So now we're starting to see BTK inhibitors in first line, which was something that we've been doing in CLL for a long time. So my easy answer would be, okay, just give a BTK inhibitor. It's great for CLL and is going to have activity in mantle cell lymphoma, but it's not really the right answer, right? So the management is not exactly the same. The expectations are not really the same. So you really need to try to understand what you really have, because there's still some nuances on how you manage. For example, for mantle cell lymphoma with TP53 mutation, we know that these patients, mainly if they have blastoid presentations, pleomorphic ones, they still benefit from some chemotherapy. So BTK inhibitors by themselves might not be sufficient. So I assume that this patient has been monitored because maybe had leukemic and mantle cell lymphoma, or CLL look pretty much the same. But I would really try to get down to the bottom of it and really understand, because the treatment is similar, but not exactly the same.
So would that be a scenario where you would recommend perhaps they get a second opinion from a specialist or get a consultation done?
I think that it's a very good idea, because a lot of times you will have some nuances that a general pathologist might be missing, and that you really get that extra little niche with a lymphoma pathologist or a lymphoma expert. So yes, a second opinion is very helpful in defining this. And it might be simple, a single opinion. Come sit down, review everything, said, yeah, I think you really have mantle cell lymphoma and for this and this reason. So my suggestion is this. And you can safely go back and do it with your primary doctor close to your house, not having to travel long distances to a specialist. But you definitely want to get down to the strict diagnosis, mainly if you're going to start therapy.
All right. And I think that's going to close out our questions for the day. So thank you, Dr. Alencar. That was super, super helpful. I love your analogy of the lion in the cage. That is, out of all the ways that I've heard BTK inhibitors described, that it has to be one of my favorites. So every time I hear you say that, I just reminds me how much I love that one. So thank you for joining us.
Thank you,
All
Dalton. It's a
right.
pleasure to be here. Thank you very much for having me.
Excellent. And then before we go, I wanted to give out a reminder to the community to check out our new CLL SLL therapy guide. This is a really cool new resource that we have to help patients understand really these different treatments, many of which were discussed today. But this can be a really helpful way to figure out what's the right treatment and learn a little bit more. So this guide was developed by HealthTree in collaboration with patients and care partners and specialists to ensure that it's relevant to you. So it helps you learn how these therapies work, as well as different side effects, things like that. So highly recommend checking it out. I think it's a really great resource. And then we do have an upcoming webinar for CLL. This will be on February 28th at 1 p.m. Eastern Time. And this one's a pretty cool one, a little bit different than others that we've done here. But this will be an emotional wellness for chronic lymphocytic leukemia patients. And this will be with a psychologist who specializes in working with oncology patients. So really geared towards the CLL patient experience. So if you're interested in that and want to learn how to maybe help manage some of that anxiety that can come along with watch and wait or not knowing what treatment's next, I highly recommend checking this one out. I think it's going to be a great event. And then one final shout out to AbbVie, our sponsor for today's event. I think, or I know that we wouldn't be able to do this without them. So thank you to AbbVie. And finally, and most importantly, thank you to each and every one of you for joining us today. We're working hard to build this CLL community, and we wouldn't be able to do it without you. I've gone ahead and attached my email to the slide here. Please feel free to reach out with any questions that you have about CLL, about HealthTree, or even if you just want to talk. I'm always available, so never hesitate to email me. And I just want to say that I appreciate you all, and I hope that you have a great rest of your day.